So you can simply pause this video and you can try to find out what is the problem. So once we are done, I'll start explaining here. So we know that this is an ECG where we actually see positive P wave, then PR interval, then Q, then R, then negative wave S, then a positive T wave, and then this is the baseline. So this is basically baseline. This running is all baseline. So this is the most important line, which is a baseline. Above this is all positive, below this is all negative deflection. So we know the positive waves, which are P, R wave and T wave. These are all positive wave, and positive means there is a good muscle contraction. So what we see here, if you very closely see here in V1, V2, in V1, V2 it is all T wave is positive. This T wave is positive. This is T wave. In lead V2 also we have good T wave positive. In lead V3 also we have around a positive T wave. In lead V4, as soon as we come, then there is a negative deflection. We can see there is a negative T wave. In V5 we have a good negative T wave, and in V6 also we have good negative T wave. So T wave is negative here. T wave is negative here. T wave is negative here. So here it is not only T wave which is negative. If we can see, if we zoom in, I told you that this is a baseline. This is the baseline. So this is a positive baseline which is running everywhere, which is running here. So this is a positive baseline. So when we see in lead V1, V2, V3, the baseline is positive. I mean, baseline is there. But as soon as we come into V5, we see that this baseline is there. But there is ST wave depression is also there. So if you see here, so it is not only the T inversion is there, this is T inversion, but also what we have is this ST segment which was supposed to be here, it is there. So there is ST depression which is pretty significant by around 2 to 3 millimeters. So we can see this ST depression in V5, V6. It is not there in V1, V2, V3 and in V4. And we can see this ST depression here as well in lead 2, lead 3 and in lead AVF also. So if you can see, this is lead AVF, lead 2 and lead 3. In lead 3 it is not that much prominent, but in lead 2 we have very well ST depression of around 2 millimeter. So there is ST depression of around 2 millimeter and T wave inversion of 2 millimeter. So what we have in this ECG is ST T changes, that is ST depression and T wave inversion in lead 2, 3 AVF and in lead V5, V6. So this patient was not having any chest pain, not any shortness of, this patient had shortness of breath, but on exertion. So in presence of this ST depression, in absence of a significant chest pain, so this was a casual patient in the OPD. And what we had is, what we see in here is, the second thing which is very important is QRS. So if we can see, as I told, this is the baseline. So from this baseline, this is 5 millimeter, this is 5 millimeter. Just calculate this small box. One small box is 1 millimeter, and this is a large box. So this large box is 5 millimeter. This large box is 5 millimeter. This large box is 5 millimeter. So if we can see here, there is around 5 millimeter, 5, 10, 15, and 18. So around 18 millimeter strong QRS is there in V5, in V6, and at the same time we have around strong S waves in V1. So exactly opposite. More strong is the R, more strong is S in V1 and V2. So this is 5 and this is 5, 10 and around 2. So around 12 millimeter of S wave. So to call it as LVH with strain, LVH means what? It's left ventricular hypertrophy. We must understand this is the heart. This is heart. So this is right atrium, this is right ventricle, this is left atrium, and this is left ventricle. This is how we see heart in echocardiography or in real life, basically. So this is LV, and how we place this is basically part of precordium. So this is will be chest. This will be basically nipple sides or nipple. So when we place these leads, we place V1 here, V2 here, V3, V4, V5, and V6. So this is how we place leads. That is the reason why we get a very strong R wave in V5, V6, because there is a large left ventricular mass here. Whereas in V1, V2, a very small mass of LV will be there. There will be right ventricle, which has a very low thickness. So left ventricle has a thickness of around 1 centimeter, whereas right ventricle is around 3 to 4 millimeter in these sides. That is the reason why in V1 we get a very small R waves. In fact, we get S waves, whereas in V3, V4, V5, V6, we get a good R wave because we have a good left ventricular mass. Good is the mass, large is the mass, larger will be the R wave. So what we are seeing here, that this presence of ST depression and T inversion usually indicates that the muscle mass is significantly there and it is getting lesser coronary flow. Means it very significantly may imply that the mass of the left ventricle is huge. Why it is huge? Because R is very prominent. R is very, very prominent. That is the reason why more is the mass, stronger will be the R wave. So, in that sense, mass of the left ventricular is pretty good. This is reflected by the R wave. Also, prominent S wave also reflect the same thing, that the mass of the left ventricular is huge. So, in the right-sided leads, which is V1 and V2, we get a strong S wave. And the second thing, if the mass is more, there will be compared to lesser blood flow to the mass, because epicardial artery is fixed, its size is fixed, but mass has increased over a period of time. So mass is more, so R is more. But as mass is more, but flow is less, the blood flow is less because of any reason, that causes the presence of STT changes because of the poor perfusion, because of the mismatch, because the mass is more but the flow compared to flow is less. That is the reason why STT changes are there. So we get very good R waves in young male or female patients as well, but there you won't get this STT changes. So no STT changes. Tall R waves means mostly the patient is young and asymptomatic and a normal variant, but strong R waves in V4, V5, V6, which are lateral leads, in 2, 3 AVF, which are inferior leads, means the mass is more, the STT changes are there, means the chances is very high that the mass and the supply to that left ventricular mass is discordant. That is the reason why this typical ECG pattern we call it as typical LVH with strain pattern. So this LVH with strain pattern, to call it as LVH, we must have lead V5, V6 must be at least more than 25 millimeter. But here it is around 20 millimeters, where we very commonly get more than 10 millimeter of S wave. So this is almost as good as this LVH criteria only. And here we can see that this strain, to call it as strain, we have this ST depression and T wave inversion, which tells us that there is a strain. The blood supply to the mass is less. So what could be the cause? This is the first important thing that we discuss is LVH with strain. The second thing is why this patient has this type of pattern, or what disease this patient can have. It's very simple. This is RA, this is RV, right ventricle. This is LA and this is LV. So we know structurally aorta will be here. So this is outflow of the aorta, and this is inflow from here. This blood comes here. So blood is coming here. into the left ventricle and blood is going out through the aorta. This is how LV looks like. So one thing that come to know that this mass is significantly increased. Now, why would this mass increase? This mass will increase if this aorta, if there is obstruction to this aorta. So if there is obstruction to this aorta, this will have to put more and 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 more pressure to make sure that this blood goes from this left ventricle outside into the aorta. So why there can be obstruction to the aorta? Simple thing. The patient may have aortic stenosis. So it can be subvalvular aortic stenosis or it can be valvular aortic stenosis. In short, we call it as left ventricular outflow obstruction. So left ventricular outflow means it is aorta. So if there can be aortic stenosis, so stenosis means there will be a narrowing. So narrowing, so blood cannot flow or pass very easily. That is the reason why this has to contract very heavily to make sure that all the blood or significant amount of the blood goes out of the left ventricle. And second most common cause is hypertension. So what is hypertension? Hypertension is where the systolic blood pressure or the diastolic blood pressure will be high. So in short, the blood pressure in the aorta system will be high. So pressure is high means what is that? Means against this high blood pressure, where the blood pressure was supposed to remain systolic around 140, if it is around 180, 160, 170 at all the time, 24 hours, 7 for 1 month, 2 months, 3 months, 6 months, definitely the LV has to pump against the high blood pressure against the aorta. So that again puts more pressure to the left ventricle. More pressure means this LV or left ventricular is doing gym throughout the day 24/7. So when we do gym, muscle definitely goes into hypertrophy. That is the reason why patient get into left ventricular hypertrophy. So this ECG is very typical. This patient actually had severe aortic stenosis with LVH with strain. So this particular patient was having severe aortic stenosis. The second most common reason is hypertension, which is poorly controlled, and the other causes which I can tell you is where the blood flow is coming more. So if the patient has mitral regurgitation, so there will be more and 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 more blood flow coming into this LV. So more blood flow, so LV will have to pump more and more and more and more and more blood. So again it is like doing a gym, so it will cause LVH with strain. Other thing is aortic regurgitation. So in aortic regurgitation, the blood will go out and will again come into the LV. So more blood will come into the LV. So it can again cause more pressure. Same is like patent ductus arteriosus, ASD, VSD. So any disease which causes more pressure into the left ventricle, like hypertension or aortic stenosis or left outflow tract obstruction, will cause LVH with strain, or volume overload like mitral regurgitation, aortic regurgitation, patent ductus arteriosus, aortic atrial septal defect, or ventricular septal defect. It will cause more blood to come into the left ventricle, and it can definitely present as left ventricular hypertrophy and with the strain pattern. So this was all about the LVH and with strain pattern, and we'll be looking for more. Thanks, and thanks for watching. Thanks for today.